Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm really excited tonight to be talking with Dr. Ira Byock, a family physician who found his way into hospice and palliative medicine. He's the founder of the Institute for Human Caring, and we're going to get to know Ira a bit here this evening and learn about a big project that he's been involved with. So, Ira, thank you very much for speaking with me this evening.
Oh, it's such a pleasure. Thanks for asking.
So I'm going to take you back kind of early on. Where'd you go to medical school? Where'd you go to residency? And what led you to family medicine?
I was kind of a late bloomer, or late decider to go into medicine at all. I didn't quite know what I wanted to do during college. I enjoyed school, but really was flopping around a little bit. And I actually had an aha moment during before my junior year of college that what I really wanted to do was live in a rural area and be of value to people. I wanted to serve people. I had never ever thought about medicine because, frankly, I didn't. It was the whole training thing and the many years of education and training. And I finally said, well, what are the options out there? And if I set aside the assumption that I have to do something with no more than 4 years of college, if I set that one aside, do my options expand? And I really did have this kind of lightning bolt, like, oh, I know what I want to do. I want to be a family doctor. That's what I want to do. And I never kind of looked back. I became a pre-med, though I kept it to myself so that I wouldn't spark some sort of weird dynamic in my fellow classmates and the like. I just fulfilled pre-med requirements. This is back in 1972, 73, Larry. And I was accepted at a couple of medical schools and went to the University of Colorado Medical School. I had finished college in Boulder and had the wherewithal to keep my rent receipts and my telephone and electric bills and applied to the Regents to be considered a resident of Colorado, was awarded that, and then applied to the University of Colorado Medical School as a resident. Had a great time there. This is in graduated medical school in 78. So 76, 77 began looking for, the best residency programs for rural family practice, either solo or small, group family practice. And I looked at many residency programs actually, and ended up choosing and matching in Fresno. With at the time was called the Valley Medical Center. My residency diploma says UCSF, University of California, San Francisco. But I spent 3 happy years in Fresno, with my clinic being in Selma, California, about 30 miles or so south of Fresno, serving largely Hispanic population, and doing, full service cradle to grave family medicine.
Then what happened?
Well, so that training was intense. I mean, training in Fresno at that time at VMC, Valley Medical Center, was like 2 fire hoses worth of patient care. And I kind of gravitated, thinking of myself in the future, I gravitated to doing things that I knew were going to be challenges in a rural area. Extra neonatology, operative procedures, operative obstetrics, fracture management, intensive care, all of the whole shebang. While that was my focus, and definitely the decisions for what rotations to take and what a little bit of elective time to do, and I was actually moonlighting from my second year on in the emergency department of Selma Community Hospital, which was a very maturing experience. uh, um, Along the way, I got involved in caring for people who were facing the end of life, not by some grand design, but because it seemed strange to me that we weren't doing it very well at BMC, at Valley Medical Center. This was a Boat Gray County safety net hospital, but an academic one in which everybody was really proud of the place and really proud of the level of care and quality of care we were giving people. And the faculty there was frankly great. There wasn't a lot of research going on, but there was a lot of clinical teaching. I felt very supported as a resident. But it was kind of, I couldn't help noticing that people who were acknowledged to be dying sometimes were literally, not metaphorically only, placed down the hall, weren't seen on rounds or were minimally seen on rounds, and just didn't get the time and attention that everybody, all of our other patients did. And even at the time, that seemed to me both kind of a lacuna, or like a lapse of medical quality, but also kind of a social injustice. You know, like, when did these people stop mattering? They're just dying. You know, they're just folks. And so I got involved in trying to bring our best care to them too, to deal with their pain, their bowels, the mucositis, the, skin issues, pruritus, and all of the family stuff. It sure seemed like just good medical care. Stuff that we would segment now and say is palliative care sure just seemed like providing meticulous attention to all of that stuff so that people could have the best quality of life, and, all that. And if I can, let me just go a little bit further, because I'm usually asked, so what shaped your career? And again, it looks clear in retrospect. It wasn't clear at all while I was living through it, at all. But while I was focused on all of the skill building of acute care and long-term care and fracture management and all of that stuff, neonatal, it's very interested in neonatal care and critical care, all of that. Along the side, I was trying to just meet unmet needs of seriously ill and dying people and their families, doing stuff to, like, we created a little fledgling hospice program so that these, migrant families and people from across the Central Valley of California didn't have to sit in the waiting room of the emergency department for 4 or 5 hours to get their Thai 3s refilled. Or, the people who motivated me were the occasional person I'd see in clinic or in the ED who had cancer and was on some opioids and was being admitted for rule-out bowel obstruction, when if you took a careful history, they had just been constipated for the last 10 days. And now, yeah, they looked like they had a bowel obstruction, but no, they just needed, this could have all been prevented. This was completely preventable. Anyhow, in dealing with all that and in meeting their needs, every once in a while, I would encounter a patient who, I'm thinking now about a hospitalized patient, who I'd see on rounds one morning and say, "How are you doing, Mr. Rodriguez?" And the patient would look me straight in the face and say, "I'm well, doctor. How are you?" Or a family would come back after their matriarch, their mom had died, and just come back and give us a baked goods or a thank you note to say, this last month, we thought it was going to be the worst thing ever. It was the worst thing, hearing that mom was going to die. But this last month has actually been the best time we've had as a family. And honestly, Larry, this resonated with me, but I didn't know what to do with it. I'm well, doctor, is it the morphine, or is it, Is he euphoric from the prednisone we have him on, or what does that mean, right? I became really intrigued, and eventually, after hearing this, and I didn't hear it often, I heard it occasionally. After hearing it a smattering of times, I started to get obsessed with, so you can be well, you can feel well within yourself, even though you know full well you're dying and you're uncomfortable and you're sad and all of this stuff is going on. And yet somebody can look me in the face and say, I'm well. What does that mean? And as a family doc, very involved with, very absolutely fascinated with life cycle, human life cycle, and family dynamics and family roles and all of this, developmental work for children and adolescents. I just became pretty literally obsessed with trying to figure out how some people can say they're well, they feel well within themselves, and other people, we can barely touch their suffering. What the hell is going on here? And how do I even understand it? How do I even think about it? How can I make it happen more often? And that really, that stream and that kind of obsession, frankly, intellectual fascination that I couldn't quite get free of, ultimately became kind of an organizing principle of what I did in my career. I did go out and do rural family practice for a short period of time, 14 or 15 months in a gorgeous town of Livingston, Montana, with a guy named Jim Meixner, who's, still out there. But the practice wasn't busy. I saw a lot of remarkable, rich cases going to by Jim and my door to the more established clinics in Livingston. Frankly, financially, I was going bankrupt. So I took a job in Billings, doing emergency medicine at the Billings Clinic, or the Billings Deaconess Hospital, and loved it. Started preparing to grandfather into emergency medicine, which I eventually did. But even along that way, was always doing some hospice care, volunteering stuff on the side. Frankly, sitting on some committee, or one or more or three committees, some local trying to get a hospice program going, or being on their advisory board, or serving as their volunteer medical director, but also at a state level or national level, was always sitting on one or more committees trying to develop, the right about the ethics and practice of care for people who are dying. Gradually, just, there started to be some sort of a discipline of hospice and very eventually palliative care that started to emerge. And I've just always, for the longest time, just as a kind of sideline and kind of hobby within my vocation, was active.
Now, take me forward to the demonstration project that you created. How did that come about?
Well, so I eventually moved from Billings to Missoula, Montana, was doing emergency medicine at Community Medical Center, but I was the hospice medical director. And again, this is, this is 1987 when I first came to Missoula. The hospice medical director, they had just gotten their Medicare certification, the hospice program. There was only one hospice program in town for the longest time. And so it was kind of a paid position, a very, very part-time paid position to be the medical director. I was mostly doing emergency medicine. Missoula is a remarkable place. It is a place that has a strong sense of itself, a community that where um, uh, the place matters. People make decisions to stay here, right? And they um, um, and a few years in, a number of myself and a couple of hospice people, but also some community organizing people, a private duty service and home health agency, and some enlightened teachers and clergy. We just sort of started meeting. I basically used a convening function, myself and a woman named Barbara Spring, my co-conspirator in this, who was a realtor in her day job, but was a kind of a community organizing person. We simply, decided we're going to have a planning meeting. And we printed some flyers and said, we want to have a planning meeting to see how we can live in community with one another rather than merely in proximity to one another here in Missoula around illness, caregiving, dying, and grieving. And 15 or so people showed up saying, we'd like to have this conversation. And out of that, we formed a steering committee and gradually a little nonprofit called the Missoula Demonstration Project. We had in our mind kind of this vision very much adapted from kind of the Framingham heart study, that as a community, we could offer ourselves as a laboratory of experience, doing stuff that was of intrinsic value for the people who live in Missoula, but also offering ourselves as a laboratory of experience for the country. And so we created kind of interest groups or committees in medicine, in healthcare, basically medicine, nursing, social work, as well as in faith communities. There was a faith community committee. Actually, there were two. There was faith community committee and a faith community leader, like clergy committee. There was a committee of educators, teachers, lawyers, funeral directors. There was an emergency EMS committee, arts and music committee. And all of them, we basically tried to nurture all of them with just a little staff support, convening function, minute taking. But we kept asking, how might we live in community with one another rather than merely in proximity around illness, caregiving, dying, and grieving? The damn thing took off. I'll tell you, there was real interest, genuine engagement by the community in these various committees, and we earned ourselves some grant money. The Nathan Cummings Foundation was one. We got at least one large federal grant around advanced care planning and a community-owned and operated advanced directive bank called Choices Bank. But we gathered enough money to kind of organize and have a tiny staff and some offices, and did some community surveys of attitudes and behaviors, kind of cultural surveys, attitudes, expectations, normative behaviors around illness, aging, caregiving, dying, grieving. I want to tell you another part of this story, but I'll stop there and let you take control.
Oh, neat control. I'm loving to hear the story, because I really don't know the story. I've read a little bit about it some time ago, but I really don't know. And I think getting a sense, because a lot of these, what I would call grassroots initiatives, they just evolve over time and mature, and the storyline isn't always quite clear. But I just want to give you the chance to tell it so that we can all hear it.
Well, it was during a time, so the Missoula Demonstration Project was most active somewhere around 1997 through 2003, I'd say. And it was during a time when there were a number of funders were looking at quote unquote end of life care. Nathan Cummings Foundation, I mentioned, was an important one for us, but there were quite a few. Soros Foundation, ultimately Robert Wood Johnson Foundation, and others. Anyway, and this idea caught attention. We applied for and got some significant grants. We ended up writing, half a dozen papers from our survey work and from some of our program development work, and created, kind of for us, by us community resources and community events. And our sense was, though I can't really, I don't have empiric data or objective data to easily point to, but I would say that we move the needle culturally. Let me tell you a quick story to illustrate what I mean. I could probably find the date of this because I have a slide of the front page I'm about to tell you about. But somewhere around the late 1990s, we approached the historic cemetery in North Missoula about an idea. Our kind of arts and culture committee did this. We had this idea to use the cemetery of Missoula as a way to explore cultural history, because there had been waves of immigration to the area, and you could go through and you can actually pick out different ethnicities, Irish and German, and all sorts of waves of people coming to Missoula through the grave sites and sections in the cemetery. And we said we'll train up docents, and we'll have maybe have them in period costume, and we'd like to do this sort of during the November holidays, or excuse me, October holidays of the Day of the Dead for Spanish American, and All Saints Day and all of that. Well, the Missoula Cemetery Board hated the idea. What? It's unseemly, and we're worried about vandalism. We don't really want to call attention to the cemetery. The cemetery is just a little overgrown, and We don't, and we, one of our, I often think that persistence is an undervalued, characteristic. So we said, all right, well, fine, think about it, and we kept coming back to them. And by it maybe have only been the second year, maybe the third year that we came to them, they finally relented and said, all right, well, we'll work with you to do this, and we'll clean up the cemetery and we'll do this. Well, so we did all of that. We trained up docents, and we had them in period piece, and we announced it far and wide, and there was, and we bought ads in the Missoulian, the newspaper, and all that. The darn thing was a stunning success. We had like 300 people, some of whom drove, an hour to come. And there was this whole thing. Well, by like the third year we did this, we did it, third year, there were classes. We did it on a Sunday, and there were classes from Sunday school or from grade school who came, and one day, so on some Monday, I think it may have been 2002. I could find it, but I'm the front page of the Missoulian has a picture of a young man, like 6-year-old Noah somebody. His name was Noah, I remember, leaning on a headstone. And below it says, Noah Kindred, I think his name was, is and class did rubbings of the historic headstones in Missoula as part of the annual festival. I can't remember what we call the festival now, held by the Missoula Demonstration Project. And I was actually in Albertsons hearing two people in front of me in line discussing this and saying, isn't that a nice thing? And I thought to myself, 3 years ago, this was unseemly, and the Missoulian would have been criticized broadly for putting putting this on their page one. And now look at this, wholesome. The culture has moved.
That's very cool. What about, you mentioned illness, grieving, caregiving, and aging.
Well,
How,
my usual four are illness, caregiving, dying, and grieving. But I put illness and aging. It should be illness, aging, dying, caregiving, dying, and grieving as being sort of the foci.
and how did you have programs that addressed each of those areas?
You bet. Yes, and more. For instance, we looked at. I mentioned there was an education committee, mostly of primary and high school teachers, that we resourced, with staffing and convening and just resourced. But their issue was, how do we normalize illness, caregiving, dying, and grieving within our education programs? Like at the time,
Like in schools?
in schools, yeah.
Okay.
At the time, the majority of discussion about supporting children around issues of grief and loss were, you would identify a child who had a death in their family, and then kind of pull them aside and offer them counseling, which really is well intended, but just often backfires. It just makes this person who's already feeling, this young child who's already feeling odd and even more special and odd, and we said, why don't we just teach illness, dying, caregiving, and grieving as part of human life, because it's kind of part of human life.
It is. Yep.
And it can be kind of a healthy, as sad and as unwanted as all of this is, it is part of healthy, full human living.
Right.
Which, by the way, is a very family practice concept, right? This is a bedrock family practice. And so we did some of that, and we got national resources, because there were a few curriculums out there that kind of did that. And we began to just make it wholesome, to introduce storytelling, reminiscing, doing legacy work in schools. Similarly, let me wedge in one more. There was a storytelling committee that formed, and they actually spun off their own nonprofit, something like what was it called? Story Keepers, I think it may have been called, which made it their business to just interview frail elders, people in nursing homes or in the community, and record their stories. And there was a little interview guide that we created, and they took, at the time, cassette recorders out, and we had the the Missoula Public Library create a section of local narratives, just recorded narratives that Story Keepers kind of generated, as a way of saying to people, your story matters to this community.
So this is like StoryCorps.
Yeah, it was kind of like an early StoryCorps type of thing. Yeah.
That's great. So I've always believed in the power of stories, and helping people to tell their story. It's kind of like Studs Terkel did. I'm not sure if you're familiar with that.
Oh,
he did
very much.
Great
Very much.
interviews. And I remember when I first encountered that, I was really, I had grandparents, but I really wasn't around a lot of older people as a young person back in the 60s. And so it was a way to experience another whole dimension of our world.
I agree. Yes, still doing a lot of that stuff. I mean, we have to scroll forward in this story. because I want to get to the Institute for Human Caring at some point. But
Yeah.
we're working with StoryCorps. We have several storytelling projects as a way to humanize healthcare.
So before I let you do that, Ira, I want to take you back and ask you, are there, what are the things that you were most proud of? What do you think made, can you speak to any metrics around illness, dying and grieving, caregiving, aging, that this demonstration project, you think really, it made a difference on the health and well-being of the people in the community?
I'm not sure I can, Larry. We did a lot of baseline surveys with the hope that we would come back in 15 years and do another, much like the Framingham Heart Study. But the demonstration project basically sunset in 2004 or 5, and we never really repeated that. We did. Well, I should just stop there on that. I would say that if you believe in the kind of the Donabidian structure, process, outcome
Right.
model of quality improvement, we clearly developed new structures. These committees, in fact, were structures. The level of engagement and programming is quite remarkable. That section of the library, the fact of Story Keepers as its own nonprofit, the Story Bank, which existed for quite a while as the community-owned and operated repository of people's advanced directives. Endless courses that happened, art exhibits, a public a 5-day collaboration with the University of Montana to hold the Pulitzer Prize winning play Wit, Margaret Edson's play, put on by the Montana Repertory Company at the university, to full houses, 5 nights, with talkback sessions after that. All of that new programming and new structure, I would say, I would claim as evidence that there was a there, that something was happening here. But we never, I can't tell you the triple aim outcomes of whether more people were dying at home or more people were dying in hospice, or they were spending less time in the hospital during the last 30 days of life. I wish I could, but even if I could, I would criticize the conclusion, because other things were happening in Missoula as well that were changing patterns of practice and patterns of care. However, clearly this was one of them.
So take me forward to the Institute for Human Caring. What's that
Well,
all
let
about?
me say, I'll get there in a minute or a few minutes. Let me say, in 1996, this July of 1996, I had given up my emergency medicine role. I had stepped away from it because I had, by that point, was so involved with hospice work locally and the Missoula Demonstration Project and sitting on endless committees, unpaid, nationally, that it felt like my old life. And I just kind of stepped away and devoted myself full time to being the hospice medical director and, the executive at the Missoula Demonstration Project. And, I was about to be, that January, I was about to take over the 1-year role as president of the American Academy of Hospice Medicine, now the American Academy of Hospice and Palliative Medicine. So I was busy, but I had to step away. Okay. The Robert Wood Johnson Foundation sent 3 people to Missoula, called me up and said, we hear you're doing a lot of interesting things. We'd love to come talk with you. And I thought they were coming for the Missoula Demonstration Project. And to a certain extent they were. I was excited beyond means. Oh, you bet. We're delighted to have you come, and and brought the board of the our little nonprofit Missoula Demonstration Project to a meeting with the RWJ, and we had this animated couple-hour meeting, and then I and these three people from RWJ sat and we had lunch, and we had a long 3 hours of the most animated, quite exciting discussion. And they said at the time that that the board of Robert Wood Johnson Foundation was setting aside $15 million and charging a grant and technical assistance project to embed hospice-like care within mainstream healthcare, bringing it upstream, concurrent with treatments and stuff. And I was really excited. Obviously, this was something that needed to happen, and they were very perceptive in some of the not only trends in healthcare, but trends in the economy and society writ large and our culture and things. We had a conversation, and I was talking about things that I rarely have a chance to talk to colleagues about. It was just great. And really about 3 hours into this meeting, I finally said, so this is great. Let me just say, I don't know what exactly why you're here, but I'll help in any way I can. You know, how can I be of help to you? And I assumed that they wanted me to be on some advisory board for this project, and I would have said yes in a heartbeat. And what they said, they looked at each other and they said, well, we're here, Dr. Byock, because we want you to direct this project. I can remember where we were sitting. I remember the day like it was yesterday. I tell you, Larry, I almost fell off my chair. To that moment, I had no idea. Had they posted that position, I would never have applied for it. Because as I said to them at the time, you're in Missoula, Montana. Do you see ivy growing anywhere? I mean, there's no medical school here. There's, direct the project, and so then that began an animated conversation. Well, who's on the short list? And I said, no, thank you. That's so cute, but we're past that. We really are offering this position to you. And really, do I have to move? No, you can do it from here. We have program offices that are scattered around the country. And so basically I accepted the position that day.
It's a hell of a conversation.
I mean, really, I don't have to move. I can do this from here, and I finally, it's so funny to recount this conversation because at some point I just kept shaking my head and taking deep breaths. And I finally said, so let me read this back to you. The Robert Wood Johnson Foundation is going to devote $15 million to shaping the future of care for people with serious illness in a way of offering hospice-like care concurrent with treatments. And you want me to help plan and design and shape that project? And they said, yes. Man, I think I can give you a yes to this one today. So I did that, and I did it for 10 years. As it was sunsetting, as it began to sunset, it lasted longer than we thought. In 2002, we thought we were starting to not fund new projects, and we had some peer work groups in surgery and critical care and pediatrics and a few other things that were starting to slow down. And I began to look at where I might take over what now we were calling palliative care at one of the academic centers that had been a grantee, or some that hadn't, but had been standing up hospital-based, basically palliative care programs. And I ended up taking a job at Dartmouth to run their palliative care program, as you know. The Robert Wood Johnson program lasted, we finally closed it in 2006. I ran it from Dartmouth for a few years. And then for the next 10 years, I became faculty at the Dartmouth Medical School, ultimately a professor of family medicine and community medicine, but also of internal medicine at Dartmouth. And then after 10 very successful, exciting years there, embedding palliative care within the fabric of medical care at Dartmouth, including critical care and a number of the cancer care and surgical specialties, the transplant programs, on and on. Starting to raise money for an inpatient palliative care and hospice center on the campus now, the Jack Burns Center for Palliative and Hospice Care. That's now a building on the Dartmouth campus. All of that had a fabulous decade. Then my wife and I decided to move back west, frankly, to be perfectly honest, because my daughter and son-in-law had moved to Los Angeles and were starting to write for television, immediately, highly successfully, and they were just on the cusp of having family. And my wife and I looked at each other and said, you know, you don't want to be a Skype grandmother. I don't want to be a Skype grandfather. We gotta, you know, figure out an exit plan here and move west. And so in mid 2013, we took an unfunded sabbatical, moved back to Missoula, had never given up our home here, where I'm talking to you from today. And after about 8 months, I did some writing and did some delayed maintenance on our home. And after about 8 months, I began to look at a way to at least have a consultancy practice or something in Los Angeles so that we could have a pied-à-terre and we could be a grandparent, because my first grandson had been born. And so here's the next chapter of this family doc, this rural family doc, and his unlikely career. I wrote a 3-page white paper. I called it A Vision for Transformation. And it was basically a little précis about how a large health system that actually believed its mission, vision, and core values could thrive in the coming value-based environment, the ACO, Romney Care, Obamacare environment. And, you know, a lot of this stuff, by the way, was part of what we were doing through the Robert Wood Johnson project, showing the value proposition of concurrent palliative care within, you know, critical care, within cancer care, within just mainstream acute care. But it's also, you know, I mean, and then I went to Dartmouth, and it's in the water at Dartmouth. I mean, this stuff is, you know, the health service research and the economics of value-based care is just part of the ethos, part of the air you breathe at Dartmouth, which I embraced and loved. So I wrote this white paper about how a health system that actually believes its core mission, vision, and values could thrive in the coming ACO value-based environment. And I'm just well enough known and connected enough that I was able to have this white paper read at the C-suite of a few of the health systems and dominant health systems in Southern California. And it got traction a few places. But the Providence Health System just leapt at it. They just, you know, my first meeting with them was pretty amazing. Michael Hunn, who was the regional executive director at the time of the Providence Health and Services in LA, basically opened the meeting with me with a group of people foundation that was interested in my white paper and meeting me and all that. He opened the meeting saying, Dr. Byock, many of us know you. We've been at talks you've given or read your articles or books. All of us here have read your 3-page white paper. Let me say this. We want you to build this here. That's literally the way he opened the meeting. And then he paused for effect. And I said, if you're looking for a reaction, Mr. Hun, two things come to mind. First, so far, I am loving this meeting. And secondly, if you anticipate a negotiation in our future, let me simply observe that you just gave away your bargaining position. And we all had a good laugh. And then the next thing Michael Hun said was, yeah, but we're really serious. We really want you to build this here. We knew that we needed something beyond just more palliative care, and we couldn't quite articulate it. I should have said, by the way, and this is a piece I missed in this story, that in that vision for transformation white paper, I basically said, the knowledge, attitudes, and skills that we now call palliative care actually epitomize highly personalized care and the value proposition. Better quality at lower cost by diminishing the amount of unwanted or highly burdensome care, and by very intentionally preventing crises and complications of people who are already seriously ill. You can drive a lot of change and a lot of value through your health system, and people will feel better, their families will do better, and yet, in a value-based, to the extent your system owns financial risk for patient care, there is a win-win-win here. And that's what they bought. And frankly, that's what we're doing. The Institute began for 2 years to be incubated in Southern California. But at the inception, Michael Hun's insight was that let's bring you in with the Providence Systems acknowledgement that if we can incubate it here, this will be a system-wide, the Institute for Human Caring will be a system-wide resource. And all of that has come to pass. And we are driving change. There are now about 30 people who comprise the Institute for Human Caring. And we are driving change through the health system toward highly personalized care in ways that improve quality and diminish costs, mostly through diminishing unwanted or highly burdensome treatments, and to the extent humanly possible, caring for people at home rather than in acute care.
That's fantastic. I have to tell you, we talked the other day, and I've read all of your books, and you told me that The Best Care Possible you thought was the best of your books. And I had to go back and reread it because it's been a while since I've read it. And I agree with you. And one of the things that stuck out the most to me is the story of Sharon.
Yeah.
Very, very powerful. And the whole approach to treating this young woman as a human being, not as a patient, but as a human being, is at the core of the best care possible. And America, I think, wants that, is desperate for it, and doesn't know how to get it.
Yeah, and yet it's achievable. We have the money to do this. We have the expertise within our health care community nationally. A lot of the skills of family practice, frankly, and certainly of palliative care, offers us a path forward value-based care offers us a payment structure that finally allows us to do what we've always wanted to do. So, just for the people listening, the case of Sharon, I've been asked by her mom actually to now start using her real name, Karen, Karen Vago. Dear, young woman with cystic fibrosis who wasn't about to be a transplant candidate, had lots of psychosocial issues and all that, but we cared for her, and I, became close with through some of the most difficult circumstances, and were able to enable Karen, I think her mother would say, to be well with full awareness that she was dying. As she was leaving this life, she was well within herself, within her family. And anyhow, it's thank you for rereading Best Care Possible and for calling attention to that. These are all real stories of real people that live within me.
And the chapters in the book that follow it, really, you're articulating your philosophy of care, and a philosophy of caring, again, that I think America wants. And coming to terms, accepting that death is a part of life. And the question is not whether or not you're going to die, but how shall you live?
That's right.
Knowing that we're all going to die. You did a wonderful job addressing that particular issue. Thank you for that.
Well, thank you. That book really was kind of a capstone for me in many ways. It's the book I've wanted to write forever, and it was a labor of love, lots of labor, but also it was an effort of head and heart. Thanks.
So the Institute for Caring is now running at Providence Hospital. Is it
Providence Health System? So Providence Health System is a 51 hospital, 7 state, 900 clinic. The Providence Health System, has the whole gamut from primary care to acute care to all the specialties, to PACE, home health, hospice, long-term care. We have residences, the whole gamut. I mean, it's an enormous health system. We're trying to drive change.
That's impressive. 51 hospitals is an impressive place for an innovation. But now you've moved back to Missoula. Are you still involved with that?
I'm very much involved. Actually, the Institute offices are in Los Angeles. They've simply been closed since March 2020. But our team continues to be very effective working from home. We're actually growing. We keep sort of somehow acquiring new portfolios of work that the system wants us to do or is encouraging us to do. My wife and I had a long-term plan to kind of rebase ourselves at our home in Missoula. We've been renting for 6 years in Los Angeles and spending the large 85 or 90% of our time there, which we've had been wanting to kind of invert that. And the pandemic made it happen way faster than we thought. So very soon, once the offices are reopened, sometime this summer or early fall, I'll start flying down from Missoula to Los Angeles and spending, at least the bulk of 2 weeks a month there.
I have a final question for you. I'd like your reaction. So here you are, a young man, maybe stumbling a little bit, not sure what he wants to do with his life, finally figuring out he wants to be a physician, and a rural family physician at that. And you've gone through a lot of transformation. There are still some people, by the way, Ira, who believe that family docs take care of sore throats and runny noses, and that's about it. And you've had a dramatic impact on this country, on a number of health systems. You are a leader, from my point of view, one of the early leaders in the hospice movement in the United States. And what is your thought now about, the what it means to be a family physician, what you've done with your life? I mean, it's really,
Yeah.
it's just very impressive.
Well, we're going to do this again, right? Because there's a
Yes,
I
yes,
have this whole sense and a, you know, I'm either blessed or cursed with a clear vision of what primary care could be in the future. And I really want to talk about that because it's a rich conversation. But
yes.
I couldn't have imagined a better residency training experience. I would not trade my residency experience for anybody's. That rural family practice, intense, and it was just an intense residency. Positioned me very well, not only to practice in that rural area, but also to practice emergency medicine and ultimately become board certified in emergency medicine. You know, I was better trained for emergency medicine than many of the residency trained, emergency docs that I later practiced alongside of. For one thing, they weren't so comfortable with infants, pregnant women, a lot of gynecologic issues that were kind of just meat and potatoes family medicine for me. Sure, I'll see that kid, whatever. This was just good stuff. It also, by the way, and I wrote about this at once or twice in articles. It was the perfect training and orientation to do hospice work. This notion that as much as incurable illness and dying are problems, are medical problems to be addressed, and dying to be forestalled, sure, it is going to happen. And while it's regrettable and it is absolutely hard and unwanted often, mostly gritty at times, it is also concomitantly a normal part of human life. That orientation for me is a very family medicine orientation. This is the stuff of families. And do you want to live a happy life or a full life? Well, I choose full because, for one thing, a happy life, while the pursuit of happiness may be a inalienable right for we Americans, shit happens. Can I say that on your podcast? And sometimes, happiness is hard to achieve, and it's really hard to sustain. I mean, into every life, some rain, much fall, but a full life, yeah, we can do that. And illness and caregiving and dying and grieving is part of the, cornucopia of human life that I can help people with.
So I'm going to bring things to closure here, Ira. Thank you very much for talking with me this evening.
It's been a pleasure. I'm sorry if I ran on long, but it was a pleasure. Thanks for asking.